there ought to be some kind of host response as well. So you and I are coated with coagulative staph, right? So the average person on their skin has 10 to the 11th coagulative staphylococci on our skin. But so what, right? I mean, it doesn't mean it's a pathogen. It means it's just occupying the space that we're providing to it. So it's not always a pathogen. And finally, and importantly, the whole thing should make sense. You know, when you get all done with making this hypothesis about some disease, it ought to make biological sense. And if it doesn't, you should think some more about it. So these are the current criteria, the Hill and Evans criteria for a pathogen. Okay, so just to go through some things that why it's not obvious that certain diseases are due to infection are summarized on this slide, which is a lot of focus. And a lot of these you're familiar with. So for example, if you see somebody with Sydenham's chorea minor, what's its cause? Well, it's very strikingly associated with group A streptococci. But the group A streptococci classically occurred weeks to months before Sydenham's chorea shows up. And chorea minor is a very interesting syndrome. We used to see it a reasonable amount with rheumatic fever. We don't see much rheumatic fever anymore, but it's not obvious that it's related to group A strep because of the temporal association between the exposure of the organism and the onset of disease. Same is true for nervous tics. So a lot of people have nervous tics. Actually, it's a post-strep syndrome, and that streptococcal infection may have occurred sometime in the past. Other examples would be Guillain-Barré syndrome associated with Campylobacter jejuni. The organism causes gastroenteritis, and people resolve, and then a month or so later they wind up with Guillain-Barré, and it took a while to figure out that association. Or reactive arthritis used to be called Reiter syndrome. We don't call it Reiter syndrome anymore because why? Why has Reiter's name been stricken from the medical record? Do you still call it Reiter syndrome? You call it reactive arthritis, right? Yeah. Because Reiter was a Nazi doctor. He's just an awful person. He did awful experiments, and he was a horrible person. So it's been decided in the nomenclature, the medical nomenclature, just take his name off the books. Don't call it Reiter syndrome anymore. It's reactive arthritis. But again, here's the type of situation where you get an illness, you get an infection, and then days to weeks to months later, you get an illness. Another common reason why it's hard to recognize the infectious component of an illness is difficult to culture or impossible to culture organisms. So we talked about M. leprae. How about Whipple's disease? You know, Trophorema Whipple was easily identifiable for a long time, but couldn't grow the organism. And it was initially determined based upon its genomics and then its relationship to other pathogens. And subsequently, you know, as you may know, they were able eventually to look at the genome of Trophorema whippleii and go through the chromosome and see its growth requirements, and it doesn't make certain amino acids and so on and so forth. So they were actually able to go back and create a media that met all the nutritional needs for the organism, but now you can actually grow this organism in the laboratory. So it's an example of how you can use genomics to develop a media to grow an organism you couldn't previously grow. And Bartonella hansola has also been grown in the laboratory, of course, and we've grown it in our laboratory as well. So that is potentially grow the organism, you said, to understand what it was. And another huge problem for us is those commensal organisms that we all have that occasionally cause disease in certain individuals. And there's a big debate about them. So for example, many people in this room, if we cultured your sputum, we did an induced sputum on you and forced you to cough and looked at your sputum, some of you would have environmental mycobacteria, and the same thing in your GI tract. You know, so in your GI tract you'll have MAI and usually they don't cause any problems, but in a few susceptible individuals they do. And distinguishing a pathogen from a commensal is often very difficult. Additionally, when disease is not related to a specific pathogen, so Koch always looked at infectious disease as a specific organism invades the body and causes a disease. But what if it's a combination of organisms, or only if that combination is present will the disease occur? And there's very good examples of that. So, for example, bacterial vaginosis that you're very familiar with, used to be a lot of argument about, right? Was it mobiluncus? Was it Gardnerella? Was it this? Was it that? And realized it was none of those things. It was a complex anaerobic vaginal microflora that together caused bacterial vaginosis, and it's not really called an itis, it's an osis, right? It's not really an inflammation. It's actually an abnormal microbial community living in the vaginal introitus of women. You may have seen the New England Journal of Medicine had a fascinating article about 2 weeks ago about irritable bowel syndrome. Did you see this thing of irritable bowel syndrome? It's fascinating, right? I mean, we've all taken care of patients with the irritable bowel syndrome, right? And it's one reason I didn't go into gastroenterology, because it was, oh my gosh, another person with irritable bowel syndrome, and I don't know what I'm going to do with these people, you know. And anyway, so there are a lot of gastroenterologists who see these patients, and they've tried all kinds of things, as you may know, and they did this. I think the reason it got published in the New England Journal of Medicine was only like 300 pages or something, but the reason it was just such a innovative idea, and the results were really pretty striking. What they did is they took people with inflammatory or with irritable bowel syndrome, a non-constipating form of irritable bowel syndrome, and they gave them rifaximin. Rifaximin, which is a non-absorbable rifamycin, broad spectrum antibiotic. It's not absorbed. So the idea would be give a drug that would only affect the luminal microflora, the gastrointestinal tract of these patients, because it had been known in the past that if you study the colonic flora of people with irritable bowel syndrome compared to people without irritable bowel syndrome, they look different. And again, the argument was, well, is it true and related? Is it the commensal? Is it an unusual colonization or whatever? So anyway, so they did this experiment where they gave group of patients a placebo-controlled, double-blind, placebo-controlled trial, and they showed significant improvement in their symptoms, which lasted for months. So the treatment, I think, was 4 weeks, I think, or maybe 2 or 3 weeks, a short course of rifaximin, and then people had significantly improvement in their GI symptomatology for months later, suggesting that it was actually by reconfiguring their microbial flora in their GI tract that maybe that was associated with improvement in symptoms. Really, really fascinating idea. And again, it makes people wonder, some of these diseases that we, like chronic fatigue syndrome. I don't know how many of you have seen chronic fatigue syndrome. Something almost got me out of infectious diseases, chronic fatigue syndrome, because these patients would come in, aches and pains, and they feel horrible, and they brain fog, and they just feel awful, and this one out, and they would come to you to do something, right? Give me a pill or do something, make me feel better. And it was incredibly depressing. In fact, I used to have a clinic on Tuesday afternoon, my chronic fatigue syndrome, and I got so depressed on Monday thinking about my chronic fatigue syndrome on Tuesday. I said, that's it. I'm out. I'm not doing it anymore. So unfortunately, there are other brave individuals here that we can refer those patients to. Now, something's clearly wrong with these people, and it's most likely it got started with an infectious disease, but they have a specific incapacity to resolve that inflammatory state. I think that's probably what's going on with those patients. It's probably sooner or later we'll figure it out, but not happened as yet. And then just one other thing I just want to mention to you about is the human endogenous retroviruses. So, as you know, well, let me ask this. What percent of the human genome is transcribed into protein, as opposed to just spacer DNA, or what's referred to in the business as junk DNA? Just, makes your chromosomes and spaces things out, but doesn't really have a transcriptional start site and termination site. It doesn't generate a messenger RNA that gets converted to a protein. So what percent of our 4 megabase genome actually generates a protein? Yeah, it depends how you define it, but it's between 3 and 5%. Probably 5% gets transcribed, and only 3% actually gets translated to a protein. So what percent of the genome is endogenous retroviruses? Since you were emailed my chapter, you read this, I'm sure you know the answers, but so I won't ask again because you know the answers. 8.3%. So there's more endogenous retroviruses, which are degenerate retroviruses, which are littering and polluting our genome, than there's actually genes that make us human beings, which is pretty remarkable when you think about it. And in fact, you can argue maybe higher depending on how you define endogenous retroviruses. But these are retrovirus, very much like HIV. So they have long terminal repeats, they have a polymerase, they have an envelope, they have a gag protein, you can tell they have the genomic signature of a retrovirus, but they have point mutations in some part of their genome that does not allow them to now generate into a actual viral particle. So either in their polymerase or in their insertion or some place they've got a mutation that keeps them in your genome but doesn't allow them to be generated into actual virus. Now the problem with that is that if you happen to get now infected, or you happen to ingest or someone gives you a xenograft, if you get a primate graft for your end-stage liver disease, there's no liver transplant donors, so you get one from a chimpanzee or something, it's bad, right? And it's very risky because you can wind up complementing the defect that's present in your endogenous retroviruses with some other animal's retrovirus, and now start generating an actual viral infection. This has actually been accomplished relatively recently. They've been able to complement the deficiency in a human endogenous retrovirus and bring it back to life again. So it's also true that they're not making viruses, these endogenous retroviruses, but they're not metabolically silent as either. So you can show that there's antibodies generated towards your own endogenous retrovirus proteins. And perhaps one of the most interesting one is there's a retrovirus that produces a protein that is remarkably homologous to ribonucleoprotein 70, which is a common autoantigen seen in lupus. And it is speculated that perhaps what's happening is that some individuals, for whatever reason, this gene in this retrovirus gets turned on and is recognized as foreign. You develop an antibody, and that antibody then will cross-react to ribonucleoprotein, and that may induce a situation known as epitope traveling or migration, and actually wind up inducing an auto-inflammatory or autoimmune disease that we refer to as systemic lupus erythematosus. So, anyway, it's a lot of interesting things these days, and a lot of things we should think about. I'll just show you a couple of them. So, this is the most common. Someone asked you, what's the most common infectious disease in the world? It's probably this, which is periodontitis. So, between 30 and 80% of the people sitting in this room, depending on how you define it, have periodontitis, and why you should go to the dentist at least every 6 months, and why you should brush your teeth, and why you should floss, right? All those things, I mean, what your mother told you was absolutely, not everything she told you was absolutely right, but that was definitely correct, right? So you definitely want to brush your teeth. Because periodontal disease, chronic inflammation is not good for you. And it's very common. So here's a guy with his toothbrush trying to get all that plaque off his teeth, and that's a good thing. And it's now, a lot of people study this disease because, of course, it's why we have dentistry, and the idea would, perhaps we could do something about it. And it's been shown that it's actually a disease that requires at least 3 organisms to cause periodontitis. So you have to have these 3 organisms. You have to have Tannerella forsythia, Porphyromonas gingivalis, and Treponema denticola. If you have the 3 of them together, then you can have dental disease. Now, not everybody in their mouth has all three organisms, but you acquire through eating and drinking and sharing utensils and kissing and so on and so forth. So you wind up eventually getting colonized with these three organisms, and if you don't brush your teeth, you're going to wind up with periodontal disease. So this, of course, is a small bowel biopsy. This PS positive material, which we knew for a long time was referred to as Whipple's disease. We now can demonstrate that is the case. Now, okay, so how many cases of Whipple's disease have you seen? I've seen 3 in my entire career. Have anybody seen a Whipple's disease case? Okay, so there's a smattering. You'll see it's like 1 in 10 million incidents. So it's a very rare disease, right? But it's very interesting. But what's interesting is that Trophorema whippleyi is actually not that rare. In fact, it is now thought that many cases of people who have tropical sprue, maybe with non-tropical sprue, tropical sprue, people who live in the tropics for a long time under this chronic, unresolving diarrhea and flattening of the villi, it looks a little bit like celiac disease, actually is due to Whipple's disease. So Whipple's disease is probably the cause of tropical sprue. It's also a fairly common cause of traveler's diarrhea. So about maybe between 10 and 15% of cases of traveler's diarrhea from West Africa are due to Whipple's bacillus. So you don't wind up getting Whipple's disease, but you wind up getting infected with Trophorema whippleyi and having a short-term diarrheal illness. It can cause endocarditis. It's actually not such a common organism now that we know about it. Hepatitis C, I just have to mention, is the first genomic pathogen. So this is the first organism that the statement, I clone, therefore I exist. So this is the initial complete rejection of Koch's postulate. So they could never grow this organism. People tried for a long time. A lot of people spent a lot of time trying to grow non-A hepatitis and were unsuccessful. A lot of very smart people tried, and so then some very ingenious group from the NIH said, the heck with trying to culture this organism. Let's just see what it looks like, what the genome looks like. And so they went through a process which is basically seen here, which I won't go into in detail, but basically they didn't know if it was a DNA or an RNA. Everybody pretty much figured it was a virus. Because you couldn't culture the organism, it was passed through a millipore filter, and it was easily transmissible, and it caused a chronic hepatitis illness, very similar to hepatitis B. And so everybody knew it was a virus, but they didn't know what it was. They didn't know whether it was a DNA virus or an RNA. They said, we won't worry about it. We'll just take the blood of people that have very exuberant hepatitis, and we'll throw in RNA polymerase or reverse transcriptase, and if it happens to be an RNA virus, we'll reverse transcribe it to complementary DNA. If it happens to be a DNA virus, we'll just take the DNA, chop it up in restriction enzymes, and do a PCR, and then make a gene library of amplicons in a Fox library system, and then just sequence and see if you can come up with sequences that look like something that looks like a virus. And then if you come up with something, then you can then study the organism and determine its homology. And that's basically how the virus was discovered. And it turned out it happened to be I remember this first paper came out, which wasn't that long. It's like 1983, I think was the paper. When they first had this paper in Science, most people didn't believe it because what they had generated, what they had cloned, was a toga virus which causes dengue fever and yellow fever, and it's totally different from what people expected that it would be. But it turns out they were right, and it turns out it is a toga virus, just an unusual toga virus. It happens to be transmitted by blood transfusion. So, at any rate, there are lots of diseases, which is in your handout, to which a pathogen is probably related as an inducer or a conditional variant that requires ongoing inflammation to cause disease. And these are some associations with inflammatory diseases, which I won't go into except to ask what is Kikuchi-Fumimoto disease? Twee, what's Kikuchi's disease?
I don't know.
Okay, it's a fairly common disease in Central Asia. It's a necrotizing diffuse lymphadenopathy, acute febrile illness, causes FUOs, and it just goes away. And it's now probably relatively clear that it's due to Yersinia, actually. There's a lot of diseases that, like for example, relapsing remitting form of MS is probably related to HH6, human herpes virus type 6. And so a lot of, and I just have to mention one other brief pathogen that you should be familiar with, which is Mycobacterium tuberculosis, only because it was initially, this hypothesis was initially described by gastroenterologists here at Brown University, and they've caught all kinds of grief from this hypothesis, and nobody believes them, and so on and so forth. It may turn out to be partially correct. So inflammatory, they posited that inflammatory bowel disease is due to this unusual mycobacterial, this soil organism, tuberculosis, based upon Jones disease, it's disease in sheep where they get a chronic inflammatory process, looks very much like Crohn's disease. Now they isolated this organism from the stools of patients. It took like a year to grow the organism. So nobody believed it, thought it was a contaminant, and they're still arguing about it, but it's possible. So anyway, it's very interesting. There's a lot of neoplasms that are probably related to infectious disease. Some of these are very well known to you. So for example, Helicobacter pylori definitely is a cause of gastric carcinoma and lymphoma. And others are very well known to you, like Burkitt's lymphoma associated with Epstein-Barr virus and associated with a number of other important neoplasias that you're familiar with, the viral hepatoma link, bladder carcinoma with schistosoma. HPV is a cause of cervical carcinoma. You know a lot of these. So these are, but they were very controversial at one time. These diseases were actually infections that caused a chronic inflammatory state that resulted in neoplasia. You may have heard the big stir recently about a xenotropic murine leukemia-related retrovirus found in prostate carcinoma. So about 40% of people with prostate carcinoma, it's a very common malignancy, have sequences for this murine retrovirus. And it's thought that it probably is pathologic. So be careful, guys, when you're holding cats in your hands, you don't pick up this retrovirus. And of course, the causes of vasculitis, these are very familiar to you. Some of them are. So I'll just finish with a couple of questions. So what is this disease? Disease of little boys, primarily, occasionally little girls, but precious young people with hepatitis B will present with this exuberant papular dermatitis, and this is Giannotti-Crosty syndrome, right? So it's Giannotti-Crosty syndrome due to hepatitis B. And for a gold star today, if anybody can make this diagnosis, you get a gold star today, and so far no gold stars have been handed out. But
Rocky Mountain,
well, it's good thought, but let me just tell you, so this is a person who's asymptomatic, has no fever, no headache, no nothing, but shows up with these skin lesions, and the skin lesions are pretty impressive. So you think about Rocky Mountain.